Hello, OT friends, and welcome to the Uncommon OT series. I'm Patricia Modis, and I'm your host, a Filipino-American, native New Yorker, currently based in Los Angeles, bulldog mama, and an uncommon occupational therapist myself for the past 22 years. On this podcast, you will hear me proudly feature the unique careers of occupational therapy practitioners working in non-traditional and role-emerging practice areas, settings where OT is uncommon. I invite you to receive a dose of OT inspiration, to learn, to think outside of the box, and to be energized and motivated to follow in these unconventional paths. Happy listening. Welcome back to the Uncommon OT series, friends. I'm so excited for today's conversation. Our guest, Dr. Alicia Reiser, is the founder of Arise Above and an occupational therapist with advanced training in vision remediation, concussion care, and executive functioning. Her work bridges occupational therapy and optometry to expand access to truly integrated evidence-based neurovision care. Alicia, welcome to the podcast. I'd love for you to get us started by sharing a little bit about yourself and some of your favorite occupations.
Well, thank you for having me. My name is Alicia Reiser, and I have been an OT for 24 years. I started off in various settings in SNFs, and then I was in acute care and transitional skilled units, and I really fell in love with the neurological population. My first love really was stroke care. And with the vision that kind of goes along with that, I started to develop an understanding of field cuts and neglects and hemianopsias and all of those kinds of things. And then I transitioned to outpatient, where I started to treat concussions. It was when we started to realize that it wasn't just 10 days, you'll be better, there's no therapy, sit in a dark room, that sort of thing. And so started to deal with the cognitive part, but then also realizing that there was definitely a visual component that was going along with this. The problem was there was no real place to refer to in our area, because optometry, who specialized in this field, they were like 45 minutes away, an hour away in New Jersey. I'm on the border of Pennsylvania, or they had to go down to Philly. And so it was a struggle for us to figure out who to refer to. And I had always thought later in my career that I would maybe want to expand into teaching. So kind of thought I might want to go back for my doctorate. And so I came upon this program that was being started at Salus. And I had taken a vision class by Dr. Mitchell Scheinman. And at that class, he had just said that they had started marketing for this program. It was for a clinical doctorate in vision remediation. And it seemed to be the path that I wanted to go along. And so the clincher for me, I am a huge science person. And so my mother had just passed away in March of that year. And in April, I had taken that course. And so he was describing how his wife is an OT. That's why he understands that occupational therapists can do this sort of thing, working with optometry and getting a great interprofessional kind of collaboration going on. And he was talking about his wife, and her name was Maxine. And my mother's name was Maxine, which is not a very common name. So I was like, this is it. This was meant to be. I'm going to sign up and go back for my clinical doctorate after 17 years of being an OT. And so I did that program, and in 18 months, I had my clinical doctorate and started my own private practice, working alongside optometry and working with them and collaborating with them, because that is the mainstay of making this relationship work when you're dealing with this population, for sure.
Oh, amazing. So I didn't realize that the program at Salus had a specific sort of focus on vision remediation.
They do. And I still believe that they're the only program, doctorate program in the United States that does do this coursework. And so again, it's taught by an optometrist. So we learn the skills for that. And then we get our clinical doctorate in the other areas of, management and research and grant writing and all of that sort of thing. But the track is taught for vision remediation by an optometrist.
Incredible. Fun fact, my dog's name is Maxine.
And you said before that your grandmother's name was Alicia. This is new.
There's too many interwoven connections there.
I love it. I love it.
So congratulations on, achieving your doctorate and for finding a program that's so closely linked to what exactly you wanted to pursue.
It really was a perfect fit. And I was excited to, learn about that. And then you get your clinical doctorate and you're ready to go out there and you're ready to, take the bull by the horns and find all these clients that you've served in the past. And you're like, oh, this totally would have been what they needed. I just didn't have the skill set. But then you have to go out there and you have to find the optometrists that want to work with you and who understand what we can bring to the table, what they can bring to the table. And it's definitely, like I said, the main point of this field is an interdisciplinary relationship. You need optometry to be working with you. This isn't a go rogue. OTs can just start using lenses and prisms and all of that sort of thing. We definitely need their feedback and their diagnoses and their teamwork and approach when we're dealing with this clientele for sure.
Got it. Now, I know you mentioned, your background in neuro and in acute care, and that being sort of the link to you working in vision remediation. Were there any other motivations for you to work with this population or to work with this group?
My mom was a nurse, and so I've been around, in the medical field. Like I would always go in and help in the rec department and that stuff since I was like 6 years old. And she had a special patient that I would always kind of go in and visit. And he was a very dense CVA, was aphasic and that sort of thing. So I kind of have always had this neurological background, I guess, if you will, or just like the spirit around me. And so that always intrigued me. And my mom, when I said I was going back, for my master, she's like, well, whatever you do, don't be a nurse because there's too much documentation. And little did I know, well, we're in the same boat too. Anything that a flap is documentation, right? So I really think it was just, I just fell in love with that population. And I just enjoyed how I could see the benefit of when I would work with vision, that it would improve things like cognition, like motor planning, like that sort of thing. And so the eyes truly are the window to the soul, especially when you're looking at that eye-brain connection. And I think that's what was really exciting to me, was to see those changes, that when we do ocular motor things with, with OT, with reading, line rollers, compensatory things, obviously we're trying to make them functional with that too. But what's nice about when you start adding the remedial approaches, again, when working with optometry, with using lenses and prisms, that change in the vergent system, which is, you're looking near and far, and that change in the accommodative system, which is that blur, it just changes so much when you add that extra oomph, the lenses and prisms. And so I think what's great about the OT end is that then we can bring on all of the sensory aspects that we're trained so well in. Vision is a sensory system. So we look at that. We look at the fight or flight system. That has a huge impact on vision. And we as OTs understand that, when you're in that fight or flight response, we have to get you out of that so that your eyeballs literally change in terms of how they can move and how they can focus and that sort of thing. So that's what I love about the OT spin on the vision remediation, that I think is just more expansive and holistic when we work together.
Yeah, and not a lot of OTs work in this subspecialty. Was there a particular motivation for you for sharing your journey with us today?
There's more of us coming out there, and I think we are all working in silos, and we're getting there. We're getting
Yeah.
through NORA, which is the Neuro-Optometric Rehab Association, we can find each other at, with optometry, working there as allied healthcare professionals. But I think Salus has brought a lot of us together. It's now Drexel at Elkins Park, but that's where I had gotten, it was Salus at that point. And so all of us are doing research, and as each of us, go through the program and start our own journeys, either in pediatrics, in, a neurological setting, in the school systems, we get out there, like I said before, you get this skill set, and then you're kind of like, but no one wants to work with me.
Yeah.
Or you have to find that partnership for sure. And so I think we use each other a lot. We have, little subgroups out there that are really trying to work together. So I think now is the time that we are really trying to advocate, either at the state level. My current capstone student that I'm mentoring, we are looking at creating a community of practice within AOTA and possibly having them look at writing a position paper, because remedial vision is so different than low vision. And we just want to make sure that our profession understands that and that we have the support of the profession. Because when we look at the OTPF4, there are like 41 different areas based on domain and practice and all of that sort of thing that vision falls within. And so, yes, baseline education does not begin to cover what I'm talking about when I'm talking about vision. But with advanced training, advanced certification, I think this is a perfect fit and a perfect match for occupational therapists to be in this field. And so, like I said, as Salus is getting more of a pool of graduates, as we're working more and more with optometry for them to understand our benefits and for us to understand their benefits, I think it's just a great time for us to bring this to the table. So that's why I thought this would be a great platform to kind of share what we're doing.
Yes, and thanks for being here, because as I'm sitting here thinking about, my own curriculum and what was actually covered about vision, it really was quite a little bit. And, and you mentioning the difference between remedial vision and low vision, can you share with our listeners what is like a basic difference between the two that we can sort of come away with?
Sure, and here's my elevator speech on this. That this is not comprehensive in any way, but just so that people can understand the difference. Low vision, of course, is more compensatory in nature. And so it's when there's an eye integrity issue, meaning glaucoma, cataracts, macular degeneration, diabetic retinopathy, when the actual integrity of vision, the 20/20ness of vision, is starting to lessen. And so that's when they may use magnifiers, they may use bioptics for driving, they may use different sorts of tools and accommodations to basically compensate, but they're never going to fix the actual deficit, right? You're not going to get better vision by doing therapy if you have glaucoma per se or something like that. But with remedial vision, that is typically, it's either developmental. So a lot of children will have that, where there's a convergence insufficiency or possibly a strabismus, which is that misalignment of the eye. And then a lot of times what will happen is there'll be surgery, but surgery is really just cosmetic. And so that eye-brain connection isn't always reestablished after that surgery is had. So the visual processing of information, the sensory aspect of that may not be where it needs to be. And that can be remediated. So when we talk about remedial vision, we're actually talking about fixing or remediating the coordination of the eye, the coordination of the eyeball and the brain with the visual processing centers and our occiput and throughout our brain, so that we can start to function better and actually improve how our eyeballs are moving.
Got it. Okay. Thanks for that.
Sure.
Run.
It's a common unknowing kind of difference, right? And so sometimes we get lumped in to that low vision category. And so that's why we're also trying to differentiate a little bit at this moment in time, just to kind of say, it's really two different fields that we're looking at. It's more of a compensatory model versus a remedial model, meaning, trying to improve that visual efficiency is what we call it, the coordination of the eyes and that visual information processing, so that developmentally delayed children can have, better success in school, in reading, in learning. And, those who have sustained a concussion or an acquired brain injury like a stroke, so that those that motor planning of their eyes is actually improved.
Yeah, got it. So this might be a really great time for me to ask you to describe for us your uncommon OT work. And, I know you've already mentioned here and there, but some of the needs that you're addressing and maybe the setting that you work in.
Sure. So I am lucky enough to have my own private practice, having worked in the network system as well, and knowing what we could do and knowing what we were given the time to do was two different things, right? And so I had gone off on my own working with a PT who had started her practice. She was kind enough to ask me to join her. So I had started with her, and that's when like the concussion thing started to take off after I had gotten my doctorate. So we separated after a few years just because our paths were not aligning anymore. And so I totally was following the concussion path, if you will. And so we typically get the people who have maybe done vision therapy somewhere else, or who have had OT somewhere else, but it was just looking kind of at ocular motor or maybe the cognitive piece. But we typically get those long haulers. Also, we typically get people who have comorbidities. So ADHD people who are concussed, or people who have maybe some mood disorders like anxiety or depression, and those people who their brain isn't necessarily neurotypical already, and now they have an injury on top of it. And so I always say, a neurotypical brain is supposed to work this way, path 1, and you're already compensating, you're on path 2, and now you have an injury. So now you have to reestablish path 3. And that's why you're not healing in those, typical 7 to 10 days that they, will say. And so we typically will get people who are 6 months out, possibly even a year out, just because they haven't found us or they haven't tried it. And really, we try and use a multimodal approach. So we're integrating OT with the attention. We're integrating auditory processing. We're integrating, polyvagal kind of intervention. So if people are stuck in that fight or flight, we can get them out of that. We do use some holistic kinds of things, like we use microcurrent and we use red light. And so we get them out of that fight or flight so that they can tolerate the session. A lot of times, they were like, after 15 minutes of using my eyeballs, I can't even go anymore. So it's hard to bridge that gap. And so we will use some of those modalities to help them get through the session because we have that skill set. And then we integrate, movement and functional activities and all of those sorts of things so that it's kind of an integration of a whole lot of pieces and parts, because we're looking at them as the whole person, which is what we as OTs are so good at doing. And so we know that if there's a kink in the line, at one point, it's never going to flow through to the other aspects. And so that's why with vision, that impacts attention, that impacts memory. If you're not seeing the whole picture, you're not going to take that all in and encode it. And so it looks like maybe there's a memory issue, but really it's an attention issue or it's a visual fixation issue. So we kind of really are great activity analysis kind of folks in our setting, because we're really trying to be like, well, let's try this. That didn't work. And so we'll use some different vision approaches too. Sometimes we'll use, with Prism, sometimes we'll use more of a remedial approach, and sometimes we'll use more of a compensatory approach, but it's all based on that sensory system. Some people like to push in and they need that kinesthetic feel of where their eyes are. Other people just need the image shifted within their retina and in their brain, and then that helps them. So I think, again, as OTs, we're so good at figuring out what the body needs sensory-wise and that sort of thing. We use interoception a lot. Because after a concussion, after trauma, they shut off that insula, which just means they don't know what their body signals are telling them, or they block it off just from that trauma. And so we have to reestablish that connection, which is, what are your eyes feeling? Are they burning? Are they watering? Are they, is it blurry? Are you looking near or far? You can't imagine the people who don't know if they're looking near or far just because they can't feel what their eyeballs are doing. And so it's it's interesting for sure. And that's why I love it, because every day it's different.
And you're just bringing another dimension to, I think, the collaboration. You talked about like it has to be teamwork between you and the ophthalmologist. And I can't even imagine this office or this program functioning without an OT there who might link some of these things that we're talking about.
Right. And I know there's certifications, through the optometric associations. It used to be COVD. They recently changed their names. And unfortunately, I don't know their new abbreviations. But with that, you have to work. You can be an OT and you can be certified as a vision therapist, but you have to work in the same exact office as the optometrist, and they have to have the oversight for you to sit and take the boards and that sort of thing. I just collaborate with optometrists out in the community. And so I could never sit for that certification. So it's I can't say 100% like what part of the sensory aspect they're educated on, and how the systems work. But I know that we as OTs, we have,
We have that background.
we
Have that training. Yeah.
and so I think that's where it's great to share with each other.
Yes.
We're experts in function, they're experts in vision, but it doesn't mean we both can't work together to figure out what's best for the patient. And that's always been my thing. Even if I identify the vision problem and an optometrist office does vision therapy, they can do the vision therapy there. I'm not in this to battle,
Mhm.
It's not a turf war for me. I just want what's best for the patient. And if you want to do, in your office, then that's fine with me. But know that I can help on some of the other things then maybe that aren't working well, like the memory, like the attention, like the fight or flight kinds of issues, to get them back to work.
Yeah, or to address that functional deficit that it's causing. No, okay, so this is fascinating, and I love the how it's woven into your your initial work in neuro. And I guess I want to hear a little bit more about how you got there, right? So here you are working in acute care settings, mostly in neuro types of settings. And then you decided, okay, maybe it's time to sort of branch out and, start or my own private practice. So can you speak a little bit to, what did you need in order to feel that it was time to be able to do that? Or well, what came into that type of planning?
I think it's really, and it's almost unfortunate to kind of say, but I think when you just get so frustrated, unfortunately, with the system at times, with the bureaucracy of trying to start programs, or to try and get everyone on the same page. When you're in a hospital kind of network, it's very difficult because you have to meet with your supervisor, who then has to meet with the medical director of sports med or of neurology or of wherever, pediatrics, if you have kiddos who have this issue. And I don't want to say it's too many hands in the pot, because obviously they need to have that sort of system. So I think it was really out of frustration where I was like, I know what these people need. I know that they need to be seen by an optometrist to diagnose the vision. I now have the skill set to help them get there. And I knew it wasn't going to happen where I was at. And I just had this vision of what the program would look like. And I'm pretty happy that I've pretty much established that vision with integrating, so much mental health aspects into it. Dealing with the polyvagal kind of things and working with interoception. I've been very fortunate to work with a student of Kelly Mahler, and she developed a program for brain injury using interoception. She took the pediatric framework from Kelly, and she changed it to adults and children with concussion. And so Megan has been instrumental with me, in bringing that interoceptive piece to help people change that. And so it was just a slow and steady climb, and trying to work, and find the optometrists who were willing to, say, I trust you as an OT. You've been trained under the same optometrist that I was trained under. So I know you know what you're doing, and you're obviously passionate about it, which means you're going to have more give in it. And so, it's relentless of finding that partner, but it's definitely, that's kind of slow and steady was how I got there.
Yeah, well, congratulations. What a what a niche. And really just, I'm interested to hear more about like what is a typical day like for you in your private practice?
It's really, every day is different because you don't know how your client is going to come in. Are they going to be more symptomatic because it was just Thanksgiving and then they had the stress of family, or they tried to plan dinner and it didn't go according to plan, or did they go Black Friday shopping? Are they in that sensory overwhelm? Or is the end of the year like their busy work time, where they have to get everything done? Or is it their slow time because things are wrapping up and everything's pretty much taken care of? So, patients will come in and you just have to kind of gear, what your session is going to look like. We really like to do, because we're OTs, we like to do little seasonal activities. And so we love the holidays around this time of year because we do use red green glasses a lot. So it's perfect for like, we've got all of these activities that involve red green things. And so that works on suppression. So when your eyes aren't aligning correctly, sometimes your brain just decides it's just going to shut an eye off because it's too much for it to take. Sometimes it alternates, sometimes it flashes back and forth, sometimes it completely shuts off. So by using the red green glasses, you can kind of control what the brain and the eyes are talking to each other. And so we just love this time of year because then we use a lot of red green kinds of things. But we also use so many functional kinds of activities. And so us as OTs, there's stuff everywhere, right? Because you use how we function. So we have so many games that we use because it works on so many things. Everything that we do pretty much requires vision. So we use card games. We use, Connect Four's eye-hand coordination. We use, game like Simon, the circular Simon Flash game, right? Because that's a pursuit that you're looking at. We love to use Taco Cat Goat Cheese Pizza, that card game, because that's working on processing speed, reaction time as you're flipping your cards. There's a lot of eye-hand coordination and depth perception. So we're integrating vision throughout our session. But then we also do use some of the optometric equipments after, again, they've seen optometry, they've gotten the diagnosis. The optometrist has given us the go ahead to start using those devices. So then we use things like what's called an aperture rule, or we use Quates so that they can start to get feedback on fusion. So the best way to kind of describe it is, I don't know if you remember those magic eyes, like that they used to do, like they were like 3D pictures and you had to move your eyes just in a certain way. And then all of a sudden the picture would pop and get 3D.
Yes.
I don't know if you remember.
Yes.
So it's the same kind of concept that we're getting them to see feedback based on those kinds of activities. And so we use those kinds of things. And then in our clinic, we also have the interactive metronome. So we integrate that. And then if it's return to sport, return to work, we ask them again, like, what's troubling you at work? Like, do you have 3 monitors that you're going back and forth, between, during a Zoom conversation, or do you have to always do data entry from this spreadsheet to that spreadsheet, and then you have to check it off on your paper? So it's a lot of transitional kinds of activities. And so we'll do a little bit of the optometric devices, and then we'll integrate like a typical ocular motor OT activity, like a search a word. But of course, we put the word list on the wall and we put the search a word down here, or vice versa, so that we're getting that transitional jump, between a near surface and a far surface. Or we're having them move around, or sometimes we put people on the vibration plate just to regulate them, before they even start the session. Or we had them on the bike just to warm up to get that blood flow going, so that foggy feeling might be off. Or sometimes they just might need that microcurrent device, like I talked about, to get them out of that fight or flight so that they can kind of chill out a little bit. And then we can start to move the eyes and start to have them think a little bit.
Got it. So you work with adults?
The practice does pediatrics and adults. I am
both. Okay.
Yes. So I am typically an adult clinician. But we do. So that's another kind of niche that we went through based on family diagnoses with my kiddos. So I knew that kids would age out of OT. Once they hit 10, 11, they're kind of like, you don't really need OT anymore. And I saw that with my own children as they were and trying to transition either from middle school to high school or high school to college. Those life skills weren't there. And even me as an OT, my kids sometimes didn't have some of those skills. So I was like, this is another area that we definitely need to have these transitional skills. And so I became ADHD certified. And so we always do a sensory profile and we do a vision screen on that. And I can tell you that any parent who is, seeking us out for those transitional skills, when we do a vision screen, there is always a visual inefficiency that we've noted. So, and then they start to go back and they're like, well, they were always pulled out for reading, or they need extra time. They already have accommodations, for their test and that sort of thing. So we kind of integrate the vision into the ADHD executive functioning work that we do. And then we work on some of the interoceptive skills that they may or may not have, that they've either turned off or just don't even realize that they're having, so that they can self-regulate and then that they can attend better, because if the vision is better, so that they can fixate and attend at near, and if the interoception is better, so that they can feel the build of that emotional lability that's kind of happening, but then they can regulate through breath work, through going for a walk, through going on the vibration plate or whatever, using fidgets. Once they start to get more in tune with their body, of knowing what their eyes feel like when they look close or when they look far. So that's another area that we've kind of developed within the practice. Those, and we call it the transitional life skills, because we just knew that was another missing piece. We've also had a lot of college students come to us who are kind of like, this is not like high school at all.
Yeah.
We've had later diagnosed high functioning autism folks come to us who are like, I've always struggled at work. This is awful. And then we do, a sensory profile there, and they typically too as well have a lot of visual issues. So I like to link it to, a lot of times when people are talking about autism, that central fixation, that facial recognition, which is one of the things that
markers.
Yeah. I didn't want to say symptoms, but with one of the markers, is because they can't centrally fixate, because they can't attend to that sensation of looking near. And so typically, again, there will be, some sort of visual inefficiency that's happening there. So we will work on that, that sensory integration of bringing in the peripheral world and meeting the central visual world, so that they can start to integrate, those two aspects. And that's definitely an OT sensory thing, right? Where you're trying to get that to improve. And so it's not just concussion that we treat. It is, those folks as well who kind of have that sensory overwhelm and that sort of thing.
I mean, I'm hearing a lot of through these assessments, right? That you're really helping folks understand the connection between something that they might have been feeling, whether it's a sensory thing, to its impact to their everyday life, and sort of offering an explanation for that.
Absolutely. I mean, if I had a penny for every time someone said, well, I should have come here first, or how come no one else do this? I have, it's
Wow.
stories, but I have two folks. One was actually put on schizophrenic meds because no one was listening to her. And when she was saying she was having these visual distortions, they were like, oh, they're hallucinations. Oh, after your car accident, you must now be schizophrenic. And so they put her on meds for quite some time. Obviously, she didn't tolerate the meds because she wasn't schizophrenic. Finally her driving, rehab OT was like, I think it's your eyes. And she wound up coming to me, and we're working through that right now. And so it's education on so many areas of what we can do as OTs, just again, in addition to what optometry could do if they just wanted to, take the vision remediation piece. But again, when working together, imagine the possibilities.
Yes. And this might be a great time to ask this next question. Can you share with us some recent successes or even challenges in your current role?
I think uh, insurance, I will just say that insurance is a big issue because again, they don't understand the interconnection between all of the systems and stuff. And so when they're like, well, how come they're not done in 6, 8, 10 visits? It's kind of like, we're changing their brain. It's going to take a little bit, it's
Yeah.
not just eyeballs. It's all of this other stuff that we're trying to work on too. So I think a bigger frustration really is, workers' comp or auto runs out or those kinds of things. And then so we've started this program, auto runs out, because we do take insurances at our location. And now, they can't complete the program because they're not working because they were in a car accident and they're like almost, or it should be on disability, can't return to work for a full day. So now they can't pay for the services that, would be helpful for them. But there have been so many great successes. I just discharged a lady yesterday. She kind of was a self-discharge just because of travel time. And again, it was another issue with insurance and that sort of thing. And so she's like, I'm just going to try and do the home program on my own. But, she said, I would never have been able to get back to work without what you guys have done here. And we've heard that time and time again. And the fact when people say, I just should have come here first. Why didn't anybody send me here 1st?
Mm-hmm.
Those are the success stories where you really feel like, you're making a difference. And for me, that's what gives me my feel goodness, is that I'm helping others and that, and even if it's not me, if they're not my client, if it's one of my, my employees or any of that kind of stuff, it's just to see them then learn this skill set that I have had and now have educated them on, and to see them helping those people too. And everyone who walks out the door, usually everyone who walks out the door is pretty 90% when they came in feeling pretty broken. And I think what's great too is that we have a concussion support group that is run by one of our therapists who is also a brain injury survivor who has had multiple concussions. So I think people feel safe. And I've heard that a lot of times too. You get it. I've had a concussion. Just so many of our clinicians have personal empathetic kinds of stories that they can relate to our clients, which is really why many of us become OTs. There's some connection there, right? There's some sort of impact that either another field has had on us or we just like to help people. So I think that's really the benefit of what we do.
I mean, I love that you have the support group. So other than meeting with you one-on-one, there's another place, another safe space for folks to come and share with others who have been through similar things.
Yeah. And so what's great about it too is our leader will make it according to the patient's needs, right? So when holidays come up, it's all about stress or shopping or, those kinds of things. But then also she'll be like, so who's gotten to the point where they can laugh now at themselves, and, just be like, oh, well, I forgot that now too, or that kind of thing. Or, sometimes it is more serious. Like, what are some of the mental health struggles that you've had? Or what about family who doesn't understand or that kind of thing? And they've been very good at helping each other. And I think that's what's also great, is that, yes, we're there for their support, but they also have each other. And we're close in our treatment areas as well. And there's a lot of banter just during their sessions then too, and people come in and they sit down next to the person who's always at the same hour with them. And then they start talking about grandkids. And it's just a great kind of feeling and setting to kind of see that. And so again, that's why I hope that I created like this special kind of place where it's not just me feeling good, but it's everybody who kind of walks through those doors.
Yeah, I mean, it sounds like you've built more than just a clinic. It sounds like there's a huge socialization aspect there, and people are coming there to get that kind of support.
Absolutely. Absolutely.
Ah, amazing. Can we switch gears? I know you talked about insurance and that being a big issue, and it's like, boo, insurance, making our lives more challenging all the time. So, I guess, can you share with us more about salary compensation? How do you get paid for your work?
So I would love to be private pay. I think that would be great, but based on our clients, because it's a lot of motor vehicle accidents or workers' comp, I can't charge what I would like to charge. And I think that is the biggest struggle that optometry faces when they try and do, vision therapy.
Mm-hmm.
Their realm is that, they don't get reimbursed a whole lot. It's kind of like when a chiropractor does a manipulation, they get what, I don't know, like $12 a unit or whatever. And so optometrists will also charge private pay. And they can't get the people to, pay for that. And so now you've got a conundrum here. There's a service out there that can help you, but you're not working and you can't pay for the services. And so this perpetuates the cycle. So we are able to charge, rehab codes because we're OT, but we're also integrating all of that other stuff that I just talked about. So, we're doing that therapeutic activity of looking at function and then bringing in all of those, the neuro-re-ed and the therapeutic activity and the vision piece and the holistic piece and that sort of thing. And so we do go through insurance. And so we typically will get reimbursed that way. There are some people then too, if insurance runs out, they can kind of maintain, a private pay rate. We also have some wellness packages for some of the holistic stuff that insurances don't pay for. So like the red light and the microcurrent devices that we use, we have that option for some people too. So, I'm probably not the best owner model because, I pay myself last when you're supposed to pay yourself first. But so I don't know. I'm a bad businesswoman, but I think I'm a pretty good OT.
I think you're a great OT. And also, I appreciate you for your transparency, right? I mean, this is the challenge for entrepreneurs is
It is.
insurance and billing and how do we do so that we're compensated for our great work.
Yeah, and I think that was one of the biggest things too when I separated from the PT that I was with is that we brought billing in-house and it was much better to problem solve with workers' comp and with auto when they would deny, and then we'd be able to just go directly to the source versus having to go through a third-party biller. And so those are the trials and tribulations that you learn as a private practice owner. What works best for you? Are you just going to get, same thing like with EMRs and all of that kind of stuff. We had to have their own templates because obviously there's nothing that's going to document what we're doing and that sort of thing. And so
Doesn't exist yet.
correct.
Yeah.
So it's a struggle, but it's, head down, push through, all of that kind of stuff. So
Also part of being an entrepreneur.
yes.
So on that note, any career advice for any of our listeners on how to get started on this path?
I really do hope, like I said, through the advocacy that we are trying to initiate the end of this year, the beginning of next year with the community of practice, through AOTA and through, state legislation. Like I said, there's little silos of us all over. We're all still working together, but I know Utah and South Dakota are working on their Practice Act just to allow, more ability for us working with optometry. Some states are very specific and say we can accept a prescription from an optometrist. Others say specifically lenses and prisms. Others are very vague. And so we're really trying to get that advocacy out there. But that being said, yes, there is minimal education out there. And so, there's different platforms that offer basic vision education. Myself and Megan, who does the interoception, we have a little side consulting business called NeuroT Consulting. And so we we are trying to get this message out there to help people who are kind of in the spot that I was. I'm frustrated. No one's listening to me. I know this is the problem, but no one will help me. I want to learn how to work with optometry. I want to learn how to bill. And so we're trying to get that standardized education out there. But like I said, Salus, Drexel at Elkins Park, is the only clinical doctorate program. There are some certifications that are trying to be developed through the ACVREP. I think those are the initials. But again, it's more low vision focused. And so that's again why we really felt like this is the time for us to come together across the country for those of us who are working in this area and kind of be like, we really need support from AOTA, from our state legislation. So, because we don't want to make anybody mad. We're not trying to step on toes. We're not trying to steal scopes of practice from anything. It's just no pun intended, we use a different lens when we're working with these folks. And so we're using our OT eyes. And so we just want the best for these patients. And we think this is a great program to start. And so we're trying to get the education out there. We're trying to get more certifications out there so that if you want to be in this niche, it's like hand therapy, right? You take these additional courses, but those courses aren't all out there yet. So we're in the very beginning stages, kind of like where low vision was maybe end of the 80s, early 90s when Mary Warren was trying to develop all of this sort of thing. So we're a little behind, but that's kind of, now that we understand how the brain works a little bit better, that's kind of, I think, where we're at right now. And that's where we're trying to just make sure that we do this right. We do this with optometry. We're all working together. No one is trying to, steal anything from anyone. And we're just trying to make the best for our patients.
Yeah. I love that you've started this consulting business and that you are on a mission to inform, right? And to educate other OT practitioners on how we can start on this path. It doesn't seem so clear cut. And it's also it's a mesh. Like there's concussion care, there's vision remediation, there's so many, like you talked about TBI. And so I feel like all of these are all diagnoses that we're so familiar with as OTs, and we're familiar with working on those diagnoses. But if you put them all kind of together, I think that's kind of where your specialty lies, is in how to see how all of those come together and how it's impacting one's function.
Yeah, and it's really everything like brain-based, right? So you have your developmental disabilities, you have, the non-neurotypical brain, you have, then an acquired brain injury. And so, but it's still your brain and it's still your eyeballs. So the pathways should be pretty similar. And so, you can be just a pediatric vision remediation OT. I have a very close friend out in South Dakota, like I mentioned, who that's what she does. But we're more of an adult clinic. And so you can do it to your liking, what you want to, the area that you want to be. If you want to just do, pediatric concussions or ADHD or autism spectrum, or if you want to just do, adult concussions and sports rehab and all of that. So it's as with anything with OT, it can build it and they will come. It's what you kind of make it, as long as you have that vision.
Yeah. And hopefully we'll attract some other listeners who may be interested in joining your community of practice, because I think that's really where the foundation will be solidified.
Yes, I was very happy with the amount of people who said that they would be interested in it. And so just for timelines, if there is anybody who is interested, that application is due in mid-January, and then they have their meeting in February to see if the special interest section will accept us as a community practice. So,
well, that's soon enough.
I know, and it'll be here before we know it. So I got to get my applications going.
Well, any other advice for our listeners other than those already? Very good advice.
I think the basic thing is to make sure that you're looking at vision no matter what your population is. And even if it's just to look at a saccada, pursuit, and your point of convergence, those three things will kind of get you what you need to to get them at least to the right eye care professional. So to get them to an optometrist. And hopefully there's someone in your area that you can piggyback off of and work with. But again, the biggest thing is to work with optometry. Like I said, Megan and I also have a book coming out. We just finished the book. Now we're working on the publishing thing. It's 100 functional activities through the lifespan for, that are vision related. So again, we kind of take like spot it, and then we, say what are the performance components that it's working on. We list that out for you. We give you a step by step on how to use the activity. We say how to grade it for adults, how to grade it for peds, how to upgrade it, how to downgrade it. And so there's 100 of those in that book. So we're, like I said, we're working on the publishing aspect of that. So, just
exciting.
Even if you're not working on the vergence and the accommodation piece, the higher level trained education, we as OTs are trained on how to use, ocular motor skills and those sorts of things like saccades and pursuits. So that we are trained on.
I love it. So we're definitely going to list your consulting company, your book, and where we're able to buy that. But I'm also I think one of my biggest takeaways is really, and just as a reminder, right? Because I don't work in neuro, I don't work in acute care. I work with unhoused populations. I work in an interim housing facility, but it's a reminder for me to not forget about vision and how it can really, it could be the reason.
Yeah, and I think too, when you're talking about functional mobility, like one of my big questions is, do you trip up the steps? Do you brush against the wall all the time? If you're always brushing against like your right side, you probably have a visual perceptual midline shift, which just means your eyes aren't teaming in the middle of you. They're kind of shifted over here. And so that's going to impact your function. You can work on motor and balance all you want, but if your eyeballs are still telling you the middle of you is over here versus over your nose, it's going to be an uphill battle. And so, even little functional questions like when you get in and out of the tub, do you get dizzy when you bend over, when you close your eyes, those kinds of things. Like I said, do you trip up curbs? Do you trip up steps? Do you always have to hold on? If you're at the top of the steps and you look down, do you get dizzy? Like all of those things are eye-related kinds of things. When you're reading, do you fall off the line? If you're on your phone and you transition to the TV, is it blurry?
Yes.
Does it take a second to clear? All of those things are kind of indicators that there's something going on there.
Well, thanks for that reminder. Are there any common myths or misconceptions that you can think about your current role?
I think it's really making sure that both professions understand where we sit at the table. That not all T's are trained the same. And so optometry may have to work with us. But remember that some of us are trained, and so we do have the skill set. So I think the biggest takeaway is just, I think, education, and all of the allied health fields. Again, I know you asked about, issues or things that kind of come up. A lot of times everyone thinks, oh, concussion, go to PT, do some VOR exercises, shake your head up and down, left and right, and all that kind of stuff, and you'll be fine, and that's enough. But think about if I can't look at my finger and I have two fingers and I'm just shaking my head around, my eyeballs are wibbling, wobbling all over the place, and you're not actually activating that VOR or that reflex. And so, again, PT and OT have to work together when we're talking about those kinds of things. It's a lot of communication and just awareness by everyone that if I'm doing something and it's not working, there has to be a reason. So maybe I should talk to this discipline that knows a little bit more or understands a little bit more. Same thing, just that open communication and just making sure that everybody's on the same page.
Got it.
It's not really a myth, but it's just kind of like I don't know what it is.
Well, I guess the importance of it, right? Because we all have our role, and the optometrist will have the role, but then the OT also has like this, again, you mentioned the lens, right? And us being able to, it's the way that we see things. It's the way that we see things affecting each other. And I think that's the value that we kind of bring to the table.
Mm-hmm. For sure.
Incredible. So we talked about a typical day. We talked about some salary, money matters. We talked about some advice. We talked about possible misconception, right? Or just like a misunderstanding. Um, Now I'm super excited about the fact that you have this consulting company because, that part of, my mission for the podcast is really to connect fellow OTs with each other, right? Who are
Mhm.
interested in the same things. So I have a feeling that you're just going to get quite a few responses to
Oh, I hope
after
so.
this after this episode, just because of the specific nature of your niche. And again, circling back to what you said earlier about the OT lens and how, it really we see it seems to me that we are well suited for this partnership with the ophthalmologist because of our lens and how we're able to perceive our clients and what they're going through.
Mhm. Yep. And just to know too, who to refer to. So ophthalmology is going to look more at that eye integrity sort of thing. Mixed reviews on if,
Mm-hmm.
they want to advocate for vision therapy, vision rehab, that sort of thing. Optometrists are more aware of that eye brain connection, or at least consider it. And so, after that surgery, possibly that's when then optometry will say, maybe you should go for that eye brain connection kind of thing too. It's maybe a bad analogy, but a lot of times I'll I'll compare ophthalmology to PT, where they're looking at the structure, they're looking at the strength, they're looking at, the integrity of the eyeball or of the joint or of that sort.
Uh-huh.
Where optometry are the functional people. They're the ones looking at that eye brain connection. So they're the OTs. So I kind of make that analogy, and it's no disrespect meant to any of the four professions. But I just think if you understand how OTs and PTs are different, you can kind of understand how optometry and ophthalmology are different.
Yeah, I love that. That's going to resonate with our listeners, I think.
Oh, good. I hope so. Because I think that is another one of the biggest issues, is that no one then knows who to refer to, what kind of eye
Mhm.
care professional, to go to. And then all optometrists are trained in that three component model of looking at how the eyes and the brain kind of work together, looking at that visual efficiency. But it's like us as OTs, we don't, not all of us are certified hand therapists. Not all of us are low vision therapists. Not all of us do pediatrics, right? We learned about it, but we don't necessarily, we'll have to dig off some cobwebs to kind of do that. And optometry is the same way. You have to have that love for neurovision to be assessing for that, or to be listening to your clients that come in and say, hey, I'm kind of having that. But then if they don't offer vision therapy at their office, they also then don't know who to refer to. Like, oh, so we've diagnosed the convergence insufficiency, but the only person who does, vision therapy is, now 45 miles. So it's a lot of marketing. It's a lot of, getting out there, getting to the right eye doctor, and establishing that partnership, just so that you know where they are, they know where you are, and then you can kind of work together.
Yeah. We talked about your typical day. We didn't touch upon the fact of whether you do or do you do work on I guess like on a sort of online basis or a telehealth basis, or is it all in person?
It's easier to do in person,
Mm-hmm.
obviously, because you have the equipment. But we do some telehealth, again, if insurance allows it. And we try to have them have the equipment. It's a little bit more of a struggle, because sometimes if they can't do what they're supposed to with their eyeballs, we will add a lens or a prism. If they're not in the office, we can't drop that in to kind of see if it's better or worse. When the eye doctor does better, worse, and you kind of have to figure that out. We do that a little bit then too, just to kind of see if they can fuse it a little better, if they can clear it better. So we do telehealth, but it is difficult. There are some online vision programs. We just teamed up with an optometrist, and we work with her on her vision program. And so here's the thing. This is my little soapbox then too. Um, we do have a local uh, therapy network around here who does use a lot of technology. And I think that's great. But I also feel that function and not all screen time is also just as important. So I'd rather have you try and put, this is a silly example, but like a Cheerio on a swizzle stick from a coffee cup, right? And work on that depth perception in real space, working on eye-hand coordination, than just looking at a computer screen and trying to see when the box pops out towards me.
Got it.
So we have a little bit of technology, but we don't overuse it. But again, if there's travel issues, or if they're one of those people that we think you're probably going to have to do this for the rest of your life just to like maintain so that you don't decline a little bit, then we will offer that vision online program, or just if they need that little bit of extra in addition to what we're doing. So there are some online programs that we offer, but I really just like to do the functional in 3D space versus on a flat screen.
Yeah. I'm guessing there's also apps, right, that folks can utilize.
There are. And so I think a lot of the optometry world has developed apps then too, as well. And so everybody has their preference in terms of what they're using. So again, I use my OT lens and kind of will use more function with the other equipment as like the supplements, not the major reason of what to do.
Yes. So Dr. Reiser, my goodness, thank you so much for sharing, your wealth of experience. If our listeners were interested in connecting, just to pick your brain a little bit about your specialty, would it be okay if they got in touch?
Absolutely. Absolutely. So, I will tell you that sometimes I have a hard time juggling between the two emails. So I'm going to give you both emails and you can
Well,
send it
spend
again.
both.
Right, exactly. Because I usually, at my 100% business that we do, it's ariseaboveot@gmail.com. That one I'm in it all the time, all day long, all that kind of stuff. But if you're interested more in the consulting piece, I will give you that email address as well. And that is info@neurot. So it's NEUROT consulting. info@neurotconsulting.com.
Okay, got it. And we'll list all those links with your show notes, so it'll be easy for folks to reach out.
And then we have
to you.
socials too. Facebook we use more often, but we have Instagram too. So check us out on all of that kind of stuff. We get freebies sometimes on ideas and stuff to do. So
Oh, wonderful. I'll definitely make sure we list those too. So thank you again, Dr. Reiser, for again sharing your journey and sharing your path. Such a fascinating niche. And also thanks for making yourself available to other OT practitioners who are interested in following your path.
sure. Thank you so much for having me. It's hopefully you can tell just by me speaking about it, just how much I love doing what we do. And it's just, I can see the future, no pun intended, of us really having us at this table and really working, as the healthcare field changes, we don't know where we're really going right now. And, just in general. So hopefully, if we work with optometry, it's just another area for us to grow and develop.
Yeah, and thanks to you for informing us that there's a very structured program out there that exists, that if you were really interested in pursuing this niche, there is a path for you already. It's actually a path that you've, crossed yourself. And to have resources like you is really just, you can't really get any better than that.
Well, thank you.
So thank you again for sharing and for joining us on the podcast today.
Thanks so much. It was fun.
That wraps up another inspiring episode of the Uncommon OT series. Connect with me at www.transitionsot.com. And don't forget to sign up to be part of the Transitions OT community. By doing so, you'll receive my latest compiled list of uncommon OT practice settings, the latest news on mentoring offerings, uncommon OT live events, non-traditional OT resources, and more. You may also follow me on my social media pages on Instagram and LinkedIn. And if you love this episode, head on over to Spotify, Stitcher, Apple, and Google Podcasts. to follow, rate, and leave a review. I also ask you to consider pledging your support to my Passion Podcast project by being a patron on Patreon. It is very much appreciated. Sending big OT love. Thank you so much for listening. Until next time.